Within our vessels flows a river of life, our blood. This vital fluid, a complex mixture of cells and plasma, carries oxygen, wages war against invaders, seals wounds to prevent life from leaking away. Yet, this blood can become a site of profound disorder. Blood cancers, hematologic malignancies, represent a civil war within the body. They arise not from an external foe, but from our own cells, forgotten their purpose, forgotten their limits, forgotten their allegiance to the whole. These cancers affect the blood itself, the bone marrow, where blood is born, the lymphatic system, our drainage and defense network. This is a battle in the most fundamental tissues of our being. When these cancers take hold, orderly blood production is thrown into chaos. The bone marrow, a bustling factory, can be overrun by malignant cells. This insurgency disrupts manufacture of essentials. Red blood cells, the couriers of oxygen, may falter, causing profound fatigue and a pale appearance. Healthy white blood cells, our defense against infection, can be decimated, leaving the body vulnerable. Lymphoma is the cancer that begins in the cells of the lymph system, the body's vital network for filtering impurities and fighting infection. This system's soldiers are the lymphocytes, a type of white blood cell. When these cells undergo a malignant transformation, they begin to multiply without restraint, accumulating in lymph nodes and other lymphatic tissues, causing them to swell and form tumors. This is not a fluid cancer like leukemia, but one that creates solid masses within our immune infrastructure. The most common sign, a painless, swollen lymph node, neck, armpit, groin, is often the first whisper of a gathering storm. It is a subtle clue that the body's own defenders have turned against it, building fortresses of rebellion where there should be garrisons of protection. Lymphomas are broadly divided into two major categories, a distinction that carries significant weight for prognosis and treatment. The first, Hodgkin lymphoma, is characterized by the presence of a specific abnormal cell, the giant Reed-Sternberg cell. This disease is notable for its orderly, predictable pattern of spread, often moving from one chain of lymph nodes to the next in a contiguous fashion. This predictability makes it easier to stage and often contributes to its higher cure rate, especially in younger patients. In contrast, non-Hodgkin lymphoma is a much broader and more diverse group of cancers. It is more common than Hodgkin lymphoma. Its behavior is far less predictable, spreading more widely and erratically through the lymphatic system and bloodstream from an early stage. The staging of Hodgkin lymphoma using the Ann Arbor system provides a crucial roadmap for treatment. Stage 1 signifies disease confined to a single lymph node region. Stage 2 indicates involvement of two or more regions on the same side of the diaphragm, the large muscle separating the chest and abdomen. Stage 3 means the cancer has crossed the diaphragm with nodes affected on both sides. Finally, Stage 4 represents the most advanced disease, where the cancer has spread beyond the lymph system to distant organs like the liver, lungs, bone marrow. The presence of symptoms, unexplained fever, drenching night sweats, significant weight loss, is a critical qualifier, signaling a more aggressive disease process that often requires more intensive therapy, regardless of the anatomical stage. For the nurse, caring for a patient with lymphoma involves a multifaceted approach. A primary concern is the management of symptoms and treatment side effects. Chemotherapy radiation can induce profound fatigue, nausea, and immunosuppression. Therefore, nursing care focuses on infection surveillance, energy conservation strategies. Multiple myeloma is a malignancy born in the deepest recesses of our bones. It is a cancer of the plasma cells, a specialized type of white blood cell residing in the bone marrow. In a healthy body, plasma cells are the factories that produce antibodies, the proteins that target and neutralize specific threats like bacteria and viruses. In multiple myeloma, a single clone of these cells becomes cancerous, multiplying endlessly, producing a massive quantity of a single useless antibody known as a monoclonal protein or M protein. These malignant plasma cells, called myeloma cells, infiltrate the bone marrow, crowding out the healthy cells that produce red cells, white cells, platelets, and wreaking havoc on the very skeleton that houses them. The clinical manifestations of multiple myeloma are insidious and devastating, neatly summarized by the acronym CRAB. The C stands for high calcium, hypercalcemia. As myeloma cells proliferate, they stimulate cells called osteoclasts to break down bone at an accelerated rate. This process releases large amounts of calcium from the bones into the bloodstream, causing confusion, constipation, intense thirst, and kidney damage. The R represents renal failure. The kidneys are assaulted by high levels of calcium and also by abnormal M proteins, which can clog the delicate filtering structures of the kidneys, leading to progressive renal insufficiency. The A in CRAB stands for anemia. The relentless infiltration of the bone marrow by myeloma cells leaves little room for the normal production of red blood cells. This results in a chronic shortage of oxygen-carrying cells, leading to weakness, pallor, and unrelenting fatigue. Finally, and perhaps most characteristically, the B stands for bone lesions and pain. The same process of bone breakdown creates lytic lesions, soft, punched-out spots where the bone has been eroded. The structural weakening leads to severe, often debilitating bone pain in the back and in the ribs, and places the patient at extremely high risk for pathological fractures from minimal stress or routine movement. Nursing care for the patient with multiple myeloma is a delicate balancing act focused on safety, symptom control, and organ preservation. Protecting the patient from fractures is a top priority. This involves teaching safe movement techniques, assisting with ambulation, and ensuring the environment is free of fall hazards. To protect the kidneys, nurses must encourage vigorous hydration, often 3 to 4 liters of fluid per day, to help flush the excess calcium and protein from the body. Pain management is critical, requiring careful assessment and administration of analgesics to improve quality of life. The nurse must also be a vigilant monitor of laboratory values, watching for rising calcium levels, worsening anemia, and declining kidney function, ready to intervene and alert the medical team to the subtle signs of impending crisis. The rush of immature cells, acute lymphoblastic leukemia, ALL. Acute lymphoblastic leukemia, or ALL, is a cancer characterized by its terrifying speed. It is a disease of the very young and the very old, arising from the most immature lymphoid precursor cells in the bone marrow. These progenitor cells, destined to become mature lymphocytes, suffer a catastrophic genetic injury that arrests their development and locks them in a state of perpetual, uncontrolled proliferation. These malignant non-functional cells are known as lymphoblasts. They flood the bone marrow with breathtaking rapidity, a tidal wave of useless cells that shoulders aside and suffocates the normal, healthy, hematopoietic tissue. The factory of blood production is brought to a screeching halt, not by a slow decline, but by a violent and swift takeover from within. The clinical picture of all is a direct reflection of this bone marrow failure. The 3 primary cell lines are all critically affected, leading to a classic triad of symptoms. Suppression of red blood cell production results in severe anemia, manifesting as extreme fatigue, weakness, shortness of breath, and a noticeable pallor of the skin. The patient, often a child, may suddenly lack the energy to play or even walk. Simultaneously, the marrow fails to produce adequate platelets, a condition known as thrombocytopenia. This leads to a dangerous bleeding tendency, with patients presenting with easy bruising ecchymosis, pinpoint red spots on the skin, petechiae, frequent nosebleeds, or prolonged bleeding from minor cuts. The most life-threatening consequence of bone marrow failure in all is the precipitous drop in functional white blood cells, particularly neutrophils. This condition, called neutropenia, leaves the body almost completely defenseless against infection. A common bacterium or fungus that a healthy immune system would easily dispatch can become a source of overwhelming fatal sepsis. Consequently, fever in a patient with suspected or confirmed ALL is always treated as a dire medical emergency. The very cells that are meant to fight infection are both absent and replaced by a malignant horde that offers no protection. Patients may also experience bone pain, caused by the pressure of the expanding massoblast cells within the confines of the bone marrow. Nursing priorities for the patient with all are dictated by these profound cytopenias. Infection prevention is paramount, requiring meticulous hand hygiene, the use of protective isolation if necessary, and constant vigilance for the earliest signs of infection. Bleeding precautions are equally critical, involving the avoidance of intramuscular injections, the use of soft, bristled toothbrushes, and careful monitoring for any signs of hemorrhage. The nurse is the frontline guardian, continuously assessing the patient, scrutinizing lab results for falling cell counts, and administering supportive care, like blood transfusions. Furthermore, treatments like chemotherapy, while essential for eradicating the blasts, can cause tumor lysis syndrome, a massive, rapid die-off of cancer cells that releases toxic substances into the blood. The nurse must be prepared to manage this complication with agents like allopurinol and aggressive hydration. A microscopic view shows healthy blood cells and cancerous blast cells, the slow smolder, chronic myelogenous leukemia, CML. In stark contrast to the explosive nature of acute leukemia, chronic myelogenous leukemia often begins as a slow, insidious smolder. This malignancy arises from a specific genetic accident, translocation between chromosome 9 chromosome 22. This creates the Philadelphia chromosome and the fused BCR-ABL gene. BCR-ABL acts like a stuck accelerator pedal, driving myeloid stem cells to overproduce granulocytes. These cells can mature, but are produced in overwhelming numbers and are abnormal. The chronic phase can be quiet. Many patients are diagnosed incidentally during a routine blood test showing dramatically elevated white blood cells. Symptoms are vague, persistent dragging fatigue, unexplained weight loss, drenching night sweats. A hallmark sign can be fullness in the left upper abdomen, splenomegaly. The spleen enlarges as it filters excess white blood cells. Modern CML treatment is a triumph of targeted therapy. Discovery of BCR-ABL gave a unique target. This led to tyrosine kinase inhibitors, imatinib, Gleevec, the first in class. These oral drugs block BCR-ABL, cutting power to the cancer's engine. For most chronic phase patients, TKIs induce deep, durable remissions, turning a once fatal disease into a manageable chronic condition. Much like hypertension and diabetes, nursing remains vital. Patient education and adherence. Daily oral therapy means nurses ensure exact adherence. Nurses monitor and manage side effects, fluid retention, muscle cramps, fatigue. They also provide emotional support, help patients navigate long-term illness, celebrate treatment successes. The nurses watch universal precautions and patient care, regardless of the specific type of blood cancer, lymphoma, myeloma, leukemia. The patient's body becomes a fragile landscape, and the nurse is its most constant and vigilant guardian. The consequences converge on three central vulnerabilities: infection, bleeding, fatigue. The core of nursing care is meticulous management of these threats. This requires watchfulness bordering on hypervigilance and the ability to see crisis in subtle changes. The most immediate risk is infection. Chemotherapy can decimate bone marrow, or cancer can crowd out healthy white blood cells, producing profound neutropenia. The immune system is effectively disarmed. The nurse must act as a barrier against microbes. Strict adherence to hand hygiene, screening visitors for illness, and protective isolation when needed. Constant assessment for signs of infection is required, knowing a neutropenic patient might only show a low-grade fever. A temperature of 100.4 degree, 38 degrees C is a siren call for immediate action. The second pillar is bleeding risk from thrombocytopenia, platelets plug breaches in blood vessels. Without them, hemorrhage risk soars. Nursing care follows, do no harm. Avoid intramuscular injections. Avoid unnecessary venipuncture. Apply prolonged pressure. After needle sticks, use soft bristled toothbrushes. Use electric razors. Be an expert detective. Scan for petechiae. Scan for bruises. Check stool for occult blood check. Urine for occult blood monitor for mental status changes suggesting intracranial bleed. Teach patients to avoid forceful nose blowing and to report any bleeding immediately. Finally, address cancer-related fatigue. This is profound, persistent exhaustion, not relieved by rest. It interferes with every aspect of daily life. Teach energy conservation techniques such as clustering activities and planned rest periods, activity pacing. Assist with ADLs when energy is depleted. Provide emotional support, and simply listen and validate the patient's experience. Nurses must understand this disruption to grasp the patient's predicament. The battlefield is not confined to marrow. The lymphatic system, vessels and nodes that filter fluid and house immune cells, is also targeted in lymphomas. Lymphocytes proliferate uncontrollably in this system, forming solid tumors in the lymph nodes, spleen, other organs. In leukemias, abnormal cells flood the bloodstream and circulate throughout the body. In multiple myeloma, plasma cells turn malignant, damaging bone and disrupting the body's chemistry. Deciphering the clues. NCLEX pearls and prognostic whispers. As you prepare for the NCLEX and for a career at the bedside, it is essential to distill the vast knowledge of hematologic oncology into clear, actionable patterns. These diseases, while complex, often present with distinct clinical signatures that serve as crucial signposts for diagnosis and care. For the purpose of testing and initial assessment, think in terms of these core associations. When you encounter a clinical scenario involving painless, swollen lymph nodes, especially in a young adult, your thoughts should immediately turn to lymphoma. The presence of Reed-Sternberg cells on a pathology report is the definitive clue for Hodgkin lymphoma. A key distinction you must remember: this simple lymphoma equals lymph nodes association is a powerful starting point. When a patient, particularly an older adult, presents with deep, persistent bone pain, especially in the back or ribs, combined with signs of kidney trouble and confusion, you must suspect multiple myeloma. The critical NCLEX clue is the constellation of Crab criteria: high calcium renal failure, anemia, bone lesions. If a question provides a lab report showing hypercalcemia and a patient complaining of back pain, myeloma should be at the top of your differential diagnosis. The image of malignant plasma cells eroding the very skeleton that houses them is a memorable and clinically vital concept. Think myeloma equals bones and calcium to anchor this knowledge firmly in your mind. The signature of acute leukemia is one of catastrophic multi-system failure within the bone marrow. The classic triad of symptoms, profound fatigue from anemia, easy bruising and bleeding from thrombocytopenia, high fever from neutropenia, is the hallmark of this disease. A patient with this combination of signs and symptoms is in a state of medical crisis. For the NCLEX, if a question describes a patient with a sudden onset of widespread petechiae, nosebleeds, and a fever, your primary suspicion must be leukemia. This triad is a critical red flag, signaling a complete breakdown in the body's ability to produce healthy blood cells. This is the most urgent of the hematologic presentations. Finally, in considering the future for these patients, a simple prognostic tip can be helpful. Among the blood cancers, classic Hodgkin lymphoma, particularly in its early stages, often carries a very favorable prognosis with high rates of cure with modern therapy. The outlook for non-Hodgkin lymphoma and the other cancers is far more variable, depending heavily on the specific subtype, stage, genetic markers, and the patient's overall health. Your role as a nurse is not to predict the future, but to provide the best possible care in the present. Be alert to the key signs: fever, the unexpected bruise, the complaint of bone pain. Act swiftly and with confidence. Your vigilance, grounded in this fundamental knowledge, can profoundly alter the course of a patient's life and their journey through the unseen war of blood cancer.